Hello everyone, my name is Latoya Ferguson and I will be making a presentation on the research topic cardiovascular disease in female general practitioners who provide clinical care to individuals with mental health, in particular Black African American childcare workers from ages 19 and older. Cardiovascular disease is a leading cause of death for women, men, and people of most racial and ethnic groups in the United States, killing approximately 314,186 women in 2020, or about 1 in every 5 female deaths, according to the Center of Disease Control. Review of sources for this research reveals that high blood pressure, psychosocial stress, depression, hyperlipidemia, air pollution, chemical exposures, and biological factors, along with genetic factors, among others, are risk factors for cardiovascular disease. This figure shows that the World Health Organization estimated that cardiovascular disease is a leading cause of death due to exposure to environmental pollutants, and the number of cardiovascular deaths far exceeds that for cancer and respiratory diseases. For this research, data and information was collected from literature about cardiovascular diseases, which were available in different online databases such as PubMed, Web of Science, Google Scholar, etc. The data and information were analyzed to identify environmental, biological, and genetic determinants, and any intervention by promotion or policy tools that have been implemented or should be implemented that relate specifically to female general practitioners. Of the risk factors identified for cardiovascular disease in female doctors, psychosocial stress seems to be the greatest risk factor because they tend to treat more female patients with psychosocial complexities such as childcare workers than male physicians, which lead to longer visits. This is the SWOT analysis for the research. Strengths that were identified were that there are numerous articles and journals on causes of death in physicians, cardiovascular disease being one of those main causes, in particular cerebrovascular disease. There were research articles about modifying and non-modifying risk factors for stroke in females, and research articles about the difference between the practice of a male and female doctor. So these sources were able to be analyzed in order to garner information about cardiovascular disease in female physicians. Weaknesses that were identified were that no recent national studies have been published on age at death and cardiovascular disease in female physicians, and previous studies have sampling limitations, although physician morbidity and mortality are of interest for several reasons, including the fact that physicians' personal health habits do in fact affect their patient counseling practices. Opportunities that were identified were female physicians. They now account for approximately 1/3 of the U.S. physician workforce and comprise half of all U.S. medical school graduates. Female physicians, they usually treat higher proportions of female patients than male physicians. And female physicians, they usually work in stressful workplaces and have heavy workloads, which may contribute to cardiovascular disease. So they can be educated as to how to manage work-related stress, about environmental factors, and how to limit their exposure. Threats that were identified: doctors may not have time to adequately implement some of the changes because healthcare is a very demanding field. Also, due to stigma and the concern about having a history that could make it harder for them to practice later on. Now, just to look at the risk factors that were identified in a little bit more detail. Psychosocial stress and depression generated from several factors such as the environment seem to be the dominant risk factor for cardiovascular disease in female physicians. And according to Sudha Hakor and News, 2022, burnout among US physicians is now the highest level on record, with women physicians and those practicing emergency medicine, general pediatrics, and family medicine hit extremely hard. In the first year of the COVID-19 pandemic, global prevalence of anxiety and depression increased by a massive 25%, according to the World Health Organization. And furthermore, doctors are finding themselves working in an environment or in roles that they're not adequately trained for, such as treating patients with mental ill issues. And as we know, childcare workers are among those patients. This diagram shows the health problem analysis, and it identifies the modifying and non-modifying risk factors, protective factors, direct contributing and indirect contributing factors to cardiovascular disease in female physicians. And some of the risk factors identified, which are also modifying and non-modifying risk factors, were hypertension, hyperlipidemia, air pollution, chemical exposures, and biological factors, human interaction, psychosocial stress, and depression. Protective factors were the absence of the B thalassemia trait and the absence of depression. Direct contributing factors included depression, high blood pressure, atrial fibrillation. And indirect contributing factors were decreased interaction with nature, exposure to multiple environmental pollutants, as well as demographic factors. As it relates to COVID-19 vulnerability in the target population or audience, Matsushita et al. 2020 affirms that research results suggest that hypertension, diabetes, and cardiovascular disease are independently associated with severe COVID-19, and together with age and sex can be informative for predicting the risk of severe COVID-19. According to Abu Farah 2020, people with diabetes mellitus, severe obesity, cardiovascular disease, and hypertension are more likely to get infected and are at a higher risk of mortality from COVID-19. After analyzing the information from the different sources used for this research, the following results were obtained. Risk factors identified for cardiovascular disease in female general practitioners include high blood pressure, psychosocial stress, depression, hyperlipidemia, air pollution, chemical exposures, biological factors, etc. And of these factors, psychosocial stress seems to be the greatest risk factor for female physicians. They tend to treat more female patients with psychosocial complexities than male physicians, which leads to longer visits, according to Linzer and Howard, 2018. And this has led to female physician burnout, stress, or mental health issues such as depression. Demographic information also shows that 92% of childcare workers in the US are females, and childcare workers are among the professions, along with doctors, who experience extreme burnout and mental issues, according to the childcare workers data for the US. And most of these patients are likely to be treated by female physicians. According to a news article by Garthney 2020, chronic stress and anxiety, in addition to high cholesterol, high blood pressure, and diabetes, are key factors that affect stroke risk. And these seem to be more prevalent in the helping professions such as physicians and teachers. Kumar et al. 2020 emphasized that other factors such as family history, age, gender, and genetic factors are also risk factors for cardiovascular disease. That's why, according to Kumar, management of diet, management of tobacco and alcohol consumption, as well as management of stress, increased physical activities are considered population-wide strategies for controlling cardiovascular disease. Ford et al. Also highlights that Major depression has also shown to be an independent risk factor for coronary heart disease and manifests in the presence of chronic stress, especially with the co-occurrence of metabolic and cardiovascular disease, could have important implications on cardiovascular disease, cognitive impairment, and an increased risk of cerebral infarction, which is stroke. The results show that there is consistent evidence of an independent causal association between depression and the cause and prognosis of cardiovascular disease. However, female physicians, they're less likely to seek help due to stigma or fear of not being able to renew their license. And proposed interventions for addressing this include staff awareness through forums, mobile platforms such as health apps, digital storytelling, and social media, which will be highlighted a little bit more later on when we look at the different communication channels to address this health issue. It is important to highlight that throughout this research or study that several limitations were identified, and these include the fact that approaches or methods that were used in other countries than the United States to study cardiovascular disease in doctors involved clinical trials and cardiovascular screening of both male and female physicians. However, data is mostly available for male physicians. Another limitation is that studies performed on the United States population as relates to females are generalized to represent the entire female population and not specifically female physicians. But due to the fact that female physicians now account for approximately 1/3 of the US physician workforce and half of all US medical schools, more studies are definitely needed to generate data to inform interventions for promotion or policy tools to help address the issue of cardiovascular disease in female physicians. Frank et al. Also underscores that no recent national studies have been published on the age at death and cause of death for US physicians. And physician morbidity and mortality are of interest for several reasons due to the fact that physicians' personal health habits may affect their patient counseling practices. This graph highlights perceptions of contributing factors to burnout among physicians. The data on the graph are reflection of responses from female faculty as well as responses from male faculty on how much they agree that these factors affect female physicians. And as you can see from the data, both male and female faculty strongly agree that female physicians do have more home responsibilities. They have more difficulty than men in balancing work and home life. And they also worry more about work outside of work hours and tend to see more time consuming patients or complaints. This table shows a comparison, gender differences in the stress and burnout. And you can also see from this table that females do have high level of stress and burnout compared to men. As it relates to intervention and prevention, as highlighted throughout this research, stress is identified as the major risk factor for cardiovascular disease in female physicians. Therefore, it is logical or reasonable to say that interventions should be geared towards reducing burnout or emotional stress. These interventions, they can be classified into two main categories. You have physician-directed interventions, which focus on individuals. So this include mindfulness techniques, stress management techniques, cognitive behavioral techniques, and all of this is to enhance job competence and to improve communication skills as well as personal coping strategies. The next category of intervention is organizational or structural directed interventions, and these would focus on the work environment. It involves simple changes in the work schedule and environment in order to reduce stress levels. So examples could be reductions in the workload by improved teamwork or changes in work evaluation and increment of participation in decision making. Proposed communication channels for interventions to address this health issue include staff awareness through forums, mobile platforms such as health apps, creative methods such as using digital storytelling and social media. Targeting can also be used, and this involves the development of an intervention approach for a defined population subgroup that takes into account characteristics that are shared by the group. For example, age, race, ethnicity, spoken language. Once a group is segmented, the message should be designed in a way to be maximally effective for that target group. Due to the fact that stigma and the fear of not being able to practice or to renew their license, many female physicians do not seek help for their mental health issues. And so, in order to reduce the stigma of mental health care among physicians, in an attempt to help reduce cardiovascular risk, it is recommended, according to Brewer 2021, that state licensing applications and hospital credentialing forms eliminate questions about physician mental health. And other ways to improve female physicians' mental health include comprehensive parental leave policies and sufficient hazard pay. In conclusion, the information obtained from the studies included in this research may not be necessarily be generalized to female physicians in every country, highlighting the need for further studies to be performed in different regions of the world. The lack of studies performed in developing nations with emerging economies and distinct social and cultural norms skews our understanding of work stress and its implications on cardiovascular disease and adverse health. But despite the limited study on female physicians and cardiovascular disease, there are several studies carried out on issues that female general practitioners face. Thank you so much for listening to my research presentation.